Well, we got 3 people in there. 6. Oh, we have 6 waiting. So. We got a minute. We're going to wait just a minute. I'm going to introduce you, David, and then we'll. Okay, here they come. Hello and welcome. We're so glad you're here with this update.
Hi, Ellen.
Hi. We're gonna ask y'all to mute yourselves for just a few minutes. David will just give a little presentation and talk about some things, and then we'll open it up for questions and answers. It would help if you put a message in the chat if you have a question, and then I'll call on you so you can ask it live, but just let me know if you have a question in the chat. The chat is at the bottom of your screen. Has a little bubble with the word chat under it. And I'll also be sharing some links in there, so if you find that and open it up, maybe take a minute and just tell us what city you're in while we're waiting for more people to jump on. I'm in Bradenton. I'm going to type that in right now. Got David Bibbey, our VP, is on. We've got some board members, Gretchen Gonzalez and John Gorsuch is here. And I'm Ellen Teeter. I'm the Executive Director of FSOMA. And,
I'm Randy Weng from Cape Coral.
Hey, Randy, good evening.
We've got Jacksonville, another Bradenton, Winter Garden, Brooksville, Newport Richey. Welcome to everybody.
Hey, Jeffrey.
Sandra Kahn, our president, is on.
Hey, David. Mr. Gorsuch.
I know. Nice to see you.
Okay. Well, David Bibbey's the vice president of FSOMA and has done some research and talked to the FSOMA attorney about what's going on with Triwest, and has some news. You may have heard some of the news already, but we have some recommendations for you as well about their recent actions. So David, I'm going to turn this over to you.
Ellen, your volume is still not as it should be. Some part of our discussion yesterday. I'm just letting you know. But if you're ready, I'll step in, okay? Okay, guys. Good evening. Yeah, Ellen introduced me, David Bibbey. I have a quick update for you on the news that we heard from members regarding Triwest's notifications to their providers under contract that they were sending letters for recouping overpayment of claims dating back to January 1. And this is a nationwide question. We've heard from colleagues at the ASA and from other states that the Triwest is not just targeting providers in Florida, but this is a nationwide effort. So my response last week was to work with our attorneys to come up with a plan to exercise provider rights under the existing Triwest agreements.
David, you're muted now.
David, I'm sorry, hold on.
Okay.
Yeah, I just muted everybody and was trying to unmute you quickly and couldn't do it, so.
All right. So should I just start at the beginning, do you think? There's only maybe 2 minutes.
Yes.
Okay.
A couple more people have jumped in, so.
All right. Just as well. All right. So my comments, I was saying that, it was brought to my attention last week that providers here in Florida, our members, were getting letters from Triwest regarding a recoup for claims paid dating back to January 2020. And I just wanted to reiterate that this is not just a Florida question or a region question. It's a nationwide. So
It's really breaking up. We cannot understand.
Randall, is that any better?
Yes, it
right
is.
now.
It was going, the video was stuttering and your voice was stuttering also.
Okay, guys, I apologize. Maybe third time's the charm. Usually my laptop is pretty reliable on Zoom. So hopefully we can get this in the last take. If you feel like it's breaking up again, somebody just stop me, okay? And I won't be too wordy about this. I just wanted to reiterate that we've been notified that providers have been getting letters from Triwest for recoup of overpayment of claims dating back to January 1, and that this issue affects not only Region 2, which is Florida and the surrounding states, but it's a nationwide problem with Triwest providers. So there's been a lot of discussion at the ASA and the federal level, as well as state by state, region by region. And so what I did was reach out to our attorneys for the association last week and asked them to craft language for us to exercise an appeal under the provider agreement that we all signed as Triwest credentialed providers. So in that agreement, under general provisions in Section 6, there's a process for appealing either, payment and overpayment or any aspect of your claims. And what I wanted to do was make sure we provided some standardized language for a provider to respond to Triwest within the necessary period of time to preserve their rights to appeal these overpayment claims as soon as possible. So we have that language tonight. I'm going to share it with you. We can discuss it a little bit. It's to the point. It's very concise language, but we're going to email that to you. And basically what I asked the lawyers for was a template that you can use that has a standard language that only requires you to put in the date that you were notified by them, whatever the letter date is, the individual claim number that they're suggesting or claiming that there was an overpayment on, and a couple of other details that are very specific to each and every claim. So if you've got a letter that has multiple claims on it, you want to send a request for appeal for each individual claim. So if you had a letter with 4 claims that had a total of $350 that they wanted back, you want to submit a separate appeal for each claim number with the specific amount of money that they're asking to recoup on each of those claims. And the reason we want to do that is to preserve your rights under the contract to contest the any payment or any reimbursement that you wanted to appeal related to any particular claim. So that language is prepared. You're going to get it when this presentation is over. And if I can share my screen, I'll show you the language now. The other news that has sort of trickled in the last 24, 36 hours is that the ASA was notified that Triwest has decided to cease and desist on all recoup efforts dating back to January 1. and that they're going to apply the modification for reimbursement rate to those claims, or pardon me, for those dates of service that were after April 1st. So they're not going to seek reimbursement or recoup on January, February, March dates of service or claims that were paid, and that their restructuring of our reimbursement rate will be effective April 1. That's good news, but I don't have confirmation of that in hand. I don't have any letter attesting to that from Triwest. This is just news that's come down through the grapevine. I don't have any reason to distrust that, but the important thing is that for anybody who is in receipt or has received a letter from Triwest where they're seeking recoup of claims that they are saying were overpaid, I suggest, and I really, in the strongest terms, you want to send an appeal letter for each and every one of those claims until you get a letter from Triwest saying that we've reviewed your appeal and we agree that this is not an overpayment and you owe no money. You want to get some confirmation from them that there's zero balance associated with any kind of recoup on a claim, and keep track of those. So if you have like 3 of them, it's pretty easy to track. But if you've got 30 or 40 or 50 claims dating back to the beginning of the year, you want to make sure that you have a method for tracking that you've sent the request for appeal, and that the individual claim number that you're asking them to respond to has been, nullified in some way. Okay, just as a matter of process. The next issue related to this is that I think there's still room for improvement on how whether it's Triwest or Optum is interpreting their rights or their privileges under the provider agreement in terms of making a modification to our reimbursement rates without prior notification, without written consent, and without giving us an opportunity to respond. Because the language in the standard contract basically says that they would provide that notification in writing. Under certain conditions, they're allowed to make modifications without provider consent, and they're able to do it retroactively. But I don't know that they've met the requirements based on the agreement that that's the case. They're allowed to do it in certain emergency conditions, changes in legislation, changing in certain policies. But none of this is of an urgent nature. It's something that they're doing as a matter of policy. And I think that from a fairness perspective, certainly any contracted provider deserves, written notification that this change is happening, and to have it, presented in a way that gives you, 45 or 60 days notice where you can either appeal, amend your contract, or submit a cancellation of your agreement, and essentially opt out from continuing to see patients on the fee schedule basis that's under that contract. So I'm going to continue working with our attorneys next week to dive deeper into the elements of notification and modification to the reimbursement rates under our present agreement with Triwest, as well as the one that's under the Community Care Network for Optum. Those agreements are very similar language, and basically they're there to execute as third-party administrators for the VA's policies. So that's also in play. The last thing I want to say about this whole rate change issue is typically when Medicare introduces a rate change, it's done, especially if it's going to be I say dramatic, but if it's say more than 10% or more than 20% change in the fee structure, they introduce that incrementally over a 3 to 5, but usually like a 4-year period, where they're going to have a 25% reduction of your rate over compounded over 4 years to get to the 100% amount that is being adjusted. So if we have a usual reimbursement of $100 under the VA fee schedule, and they're going to drop that to $40 and basically slash it by 60%, they would be doing that at a 15% incremental rate over 4 years if this was another Medicare program, or if we were Medicare providers. So since the VA wants to use the CMS physician fee schedule, the Medicare fee schedule as a base for the rates for us, if there's going to be such a huge shift in how much we're reimbursed, to do that in one, in one step that drops us down 50 or 60% in reimbursement can be catastrophic to a provider's ability to continue their care for veterans, and as well as it has a potential for collapsing the provider network that they've established. So I think that there's room for improvement on how this reduction, as it turns out, as a reduction in reimbursement is going to be implemented. It's just that it takes us a little bit of effort because the VA is such a large organization. You know, how do you get to the table quickly enough to affect a policy change without it taking, 3 years to implement? This is something we're going to try to do as quickly as possible, and it's going to take a little bit of effort. But those are the three things. One is we need to respond straight away so that we preserve our rights under our existing agreement. We're going to negotiate with them a little bit and see if changing from the VA fee schedule to the Medicare schedule without some kind of provider consent or negotiation doesn't seem like a reasonable, it's not clearly articulated under our prison agreement that that's allowed. You can't just assume that they can do that because they say that they can draw their fee schedule from CMS, from the VA, from provider rates, or from a common and usual rate. There's no language in the contract that says how they move from tier to tier in terms of that reimbursement. It's clear that if we were already contracted under a CMS rate originally, and that there was a change in that rate would affect our reimbursement. That's clear. But we were introduced into the VA reimbursement model in a different tier. We were brought in under the VA fee schedule because no fee schedule existed for Medicare that was recognized in this way. So there's a couple of things about the internals of how that provider agreement works that we want to challenge Triwest and the VA on, to try to do it in a more fair and transparent way. And then ultimately, if we do have to move toward using the VA's new proposed reimbursement schedule based on CMS, that they agree to do that incrementally over 4 years, because that's a common and usual practice in Medicare. Okay, let me see if I can jump to my screen share, and I'll show you the letter that we're going to provide to you guys. It looks like that's disabled from you, Ellen, for sharing the screen. And if it is, then this is no big thing. We're gonna just send it to you as soon as we close the meeting tonight. Ellen, any chance you can?
Sorry, I just changed a setting. See if that helps.
Okay, it looks like I got. There it is. Okay, can you guys see that? Do you see a letter on your screen now, Ellen? Okay, I'm gonna assume you can see it. Everybody's muted except for me.
Yes, you can. You can see
Okay,
it.
thanks, guys. So up top here, it's addressed to Triwest WPS Claims out in Arizona, because that's the address for appeals and claims for Region 2, okay? Here, you can just put in your practice name, and then it says overpayment appeal. I've received your overpayment claim, date of, this would be the date of the letter that you received, okay? Not the date of service, but it's the date that they notified you in writing. Regarding services provided by, enter your name here for provider. Based on this claim, it appears Triwest is making a claim for overpayment in the amount of, this is the amount for the individual overpayment for a particular claim. You see how those two things are next to one another? So it's maybe $52.20 for claim number 0659997, whatever, which involves services on the data service. So all of that information is going to be on your Triwest Recoup letter. So you just want to put those details into this. I request a review of the overpayment claim pursuant to Section 6 of the Triwest Provider Contract, and that's the section that addresses modification of reimbursement rates, okay? The amounts previously paid by Triwest for these claims were correct. Amounts owed for these services using the applicable rates under Triwest Provider Contract. The applicable rates are set forth by the VA schedule, which has been the basis for all claims paid by Triwest since the beginning of my participation in the Triwest program for healthcare services and VA beneficiaries. Please note that I do not authorize Triwest to reduce or otherwise offset any payments for other services. You're not going to make any consents in this appeal to allow them to attach deficiencies to your other claims. Okay, they need your consent is required to do that, and you're expressly saying that you do not authorize them to do that. In addition, to the extent applicable, I've reviewed Triwest overpayment claim in accordance to section 627.6131 of Florida statutes. This is the Florida insurance contract statutes that lay out very clearly and actually quite favorably for Florida providers the obligations for contract modifications that are required by insurers in the state. And there's a little bit of a challenge for us to try to sort out. Triwest is not an insurer, they're a third-party administrator, and they're not registered as either in Florida, even though they act on behalf of the VA. And the VA may be able to work independently of insurers just because of their federal agency. But the agreement that we have, the provider agreement, is governed by Florida law unless there's a conflict with federal law, and then federal law prevails. But let's assume that just the intimate facts of the contract are basically governed by Florida law, because it's standard contract language for provider networking, is that we're just saying right here that we've reviewed it and compared it to the statutes in Florida, and the overpayment is denied for reasons identified above. Okay, it's a very short, very sweet, clear, standard letter, and it's helpful if everybody that has claims uses that language, because ideally, if Triwest is already moving toward dismissing all of these claims, it's helpful if you have, as a matter of record, that you communicated this language to the VA, and it makes it very simple for them to say, hey, we reevaluated your claim, and based on our policies, we're not going to move forward with Recoup. And give them a chance to get out from under this, because it's a bad idea and they shouldn't be doing it. But at least you have a uniform, intelligent way to respond to each and every one of those claims that they're attempting to recoup. And it provides a mechanism whereby they have to respond to each and every one of those claims to you. So you're able to have checks and balances in your office to say that that you were notified about this, you appealed it, they responded, it's closed out, and that you won't have any more obligations to Triwest under that claim. Okay. Hopefully that's all pretty clear for everybody. And hopefully, if there's any questions about that language or any other thoughts, we can discuss it.
I do have a question. The phone call that you and I had earlier this week about the simple fact that if they can't apply to every single code. We're talking about the low back pain. The only thing they're paying on is low back pain. So if they're going to try to apply this recoup of anything or change the fee schedule for anything else but back pain and the 100 ones that you told me about, that they can't apply it across the board. So if everybody has a patient that comes in for shoulder pain, they have to go on VA schedule. They can't apply that.
I agree with you on that, but this is part of the conversation I have to have with Gabe again next week about how we then tease out that second tier. So the reason I think this is an important point going forward, because the VA refers patients to us, like you said, for shoulder, neck pain, headache, a whole host of post-chemolytic neuropathies, things that don't apply to low back pain. And just because the 97810 and the related codes exist in the CMS fee schedule now, doesn't mean that they can apply that to every ICD-10 diagnosis that they refer us to. It's a nuanced argument. I think you're right, but we have to be able to structure a cogent argument for the VA, getting that to the right people. And if we continue to see a reduction on the reimbursement rate for those services that are provided for non-chronic back pain conditions, then say, let's just fast forward. Say you saw somebody this week coming, and then they process your claim in June, and they're paying you $42 instead of the VA fee schedule. I would submit an appeal for that claim, saying that it's underpaid. You know what I mean? So we're gonna have subsequent language to deal with that going forward until we get some sort of, I say capitulation, but I mean some sort of agreement with the VA that yes, you can use the fee schedule for CMS, but you can only apply it to conditions that are recognized by CMS for use for that code. Unless the VA is saying, hey, the CMS is sort of an early adopter. We believe in acupuncture so much that you can use it for all of these indications, but we're not going to pay you any more than we do for low back pain. I mean, that might be their answer, but I think that it's worth taking them over the hurdles and having them look at the rationale and how they're applying this across the board.
Well, if they do say we're going to apply it to the low back pain, then if that's the case, then legally, I think, I'm not sure, you can say, okay, then you have to let acupuncturists bill for everything in Medicare or Medicaid, because you can't apply one thing to everything and not include it on both sides of the fence.
I would see, if we were having this discussion, if we were having this argument with CMS, I would agree with you, but wholeheartedly, and I agree with you anyway. The distinction, though, is that what happens is the VA is borrowing the fee schedule for Medicare and saying this is how we want to use it, but at the same time, they're not subject to the same limitation or a restriction on how acupuncture is used in the way that CMS prescribed in their national coverage determination. You know what I mean? CMS is saying, we like acupuncture, but we like it just for this, and this is what we're going to pay for.
Right.
The VA is sort of reaching over his neighbor's fence and saying, I'm going to cherry pick that reimbursement fee schedule for those codes, and then they may say, we can determine that it's a valid indicated for use for all of these other conditions, and not be tethered to the language that CMS used. But I'm not going to let up on this. I will get. You and I are of the same position, and I'm going to, as best I can, force or compel the VA or its representatives to make the argument as to how, like you said, how one thing applies, but the whole rest of the story doesn't. So we're not.
They're not Congress.
Exactly. So that's what I'm saying. But the thing of it is they're used to flexing their muscles pretty good and not having people push back from a policy standpoint.
So the VA is technically not an insurance company? Are they
there's that too. The VA it's not regulated like an insurance company, although maybe it should be. It's a private insurance program for veterans. But again, it's one of those things where the VA doesn't have to, I don't think doesn't have to file the same, compliance paperwork and organizational paperwork with
that sounds like
insurance commission. So it's a more nebulous, federal program. It's a little hard to, and so they probably pick and choose, which standards they want to comply with and apply to them. And the things that they don't, they can stand behind some federal law and say that doesn't apply to us. But we're going to do the best we can to make as strong a case as possible that a lot of decisions are being made about how to use acupuncture, what the fee schedule should look like, how many, what the treatment plan should look like, and all of these other decisions that, frankly, I don't know how many acupuncturists have been involved with that planning and decision making. So it's like, having the electrician decide, how many feet of tubing the plumber should use. I think that they're not operating with all the information they should to make good decisions. But they make the decisions that they want based on their own policy. So, but there's room for improvement, and we're going to try to push ourselves to the table. And whether it's FSOMA or me or somebody from our organization in state, it's a little bit of a challenge because it's a national question that requires sort of a national 50-state solution. So the ASA and some of the federal people in the Federal Association and the federal contacts that they have may be carrying the ball on this, but I'm going to do as best I can to continuing to share your point of view, a point of view I agree with, and get the best result we can for our providers.
Good.
Okay, guys.
That's like trying to say Billy, the third grade science dropout, is trying to correct Stephen Hawking.
Right. No, I agree. It is a little kooky that way, but so hopefully, it's in stages, we get them to sort of, agree to the obvious, like maybe this needs a little bit more forethought. The other thing I was going to say is maybe I can share this real quick if I know how to do it. I'm sorry, I had another document open, and let me see if I can find a way to get to that.
I believe you have to stop sharing and then,
Oh, and go back. Let me go back and see if I can do it again. Is this it right here?
we
Yeah.
have a suggestion in the chat that Jeffrey Sherman put in, make sure that when you send a letter back, that you send it with return receipt for tracking.
Oh, yeah. Absolutely. The other thing is, Ellen, I should just tell you, just so you know, I shared with the EC, the board of directors, and you and Natalia that letter just a minute ago that I showed you from the attorneys. But I made a change in that originally it was done as a memo style, and I didn't have the Arizona address on that letter. So I copied and pasted the Arizona address so that it's part of that template, because all the letters from Florida are going to that same place in Arizona. So I'll resend that to you with that standard header on it. And the providers should just put it on their personal letterhead and sign it. So this second document, I'm going to take a few minutes just real quick and show you this. This was shared to us with somebody who's a provider that does work through Bay Pines. And basically it's the community care acupuncture guidance that the VA is using. And this is, I've been a VA, non-VA provider for years, and I've never seen this, but effective January 20th, it looks again like they kind of cherry picked some of their guidance on how they're going to apply use of acupuncture from the national coverage determination for Medicare, because it's very similar. If you look here where it says standard episodes of care, it's a little blotted out here on the right, but you guys can see initial episode of care is going to be 12 visits completed in a 90-day period with a reauthorization for care. Probably if you do a secondary authorization request, they'll give you 8 more visits to be completed over the next 3 months. And that's it. That's the 20 visits that CMS had approved annually, okay, for acupuncture. But they do have a management continuation of care that allows for 8 visits to be completed over the remainder of a 180-day period. So they're looking at 28 visits for the year. And broadly speaking, they want 20 visits in the first 6 months and 8 visits in the last 6 months. It's really, I mean, that's like something that a bean counter somewhere would probably determine, because they're not a provider, they don't write plans of care, and they don't understand how to treat patients with acupuncture for especially painful conditions that we see every day. So, but that's what they're going with as of January. So this is what you should come to expect your plan of care would look like, that's authorized from the VA, probably from whoever the pain management director is, or maybe a primary care, but usually pain management. And then it looks at medical notes, and they make, and we'll share this document with everybody too. And it's basically, it's saying, well, documentation may come in a variety of formats. Basically just looking at a standard SOAP note format is sufficient for this, with the understanding that it's legible and it uses standard phrasing and terminology that would be recognizable by non-specialist peers or non-acupuncturist colleagues. So if they refer somebody to us for cervical pain, then we're going to use some sort of standard assessment for neck pain that follows a Western interpretation, or a standard classical medical interpretation. I think in instances of our diagnosis and our treatment plan, we're required to do that based on TCM. So I'd stick to that format, but everything else in terms of your evaluation and your assessment and your non-acupuncture plan of care, or your treatment. So if you use a manual therapy code, documenting, why you were doing that, what the expected outcome for using that is important and to get paid. And then certainly your prognosis would have some sort of standard terminology going forward. So what they're trying to say is that, if you expect your claim to survive scrutiny, it's going to have these elements in it. And it would be the same thing you might expect if you were submitting for, I'd say, Blue Cross or any kind of, insurance coverage that you're going to have a chart review. Like United does a lot of chart reviewing now. So I try to make sure that my notes when I send them out are something that a nurse or somebody who's a supervisor in claims is going to be able to understand. They're not going to understand our TCM diagnosis or the treatment plan based, our TCM plan, but everything else about it should be fairly familiar to them, okay? So those are things you guys want to try to stick to.
We're going to, Maury West Seminars has a basic insurance billing and another workshop on bulletproofing your documentation.
Excellent. Yeah. It becomes more and more important when we do some of this hybrid treating that we're able to sort of communicate with some confidence that to other healthcare professionals that are either reviewing our work, processing, for reviewing our work for approving a plan of care or a continuation of plan of care, is that they can kind of pick up on what we're talking about and translate it in a way that makes sense, that they can justify medical necessity for continuing the care. So again, it says when requesting approval for additional care, these are things like when we submit our secondary authorization requests, and they ask for documentation, you want to include things like the treatment goals and the establishing an outcome, how that's going to be measured, a treatment summary of what you've been doing, some sort of reassessment at intervals.
We're losing your sound again.
I'm sorry, am I better?
Yeah.
Okay, guys, I apologize. So I would just say that the treatment summary, to try to, if you've seen somebody for 8 or 10 times, you're able to consolidate that into a paragraph, and then reassessment that you've reassessed, hopefully with the objective of demonstrating some improvement. I mean, if there's no improvement, there's no improvement. Sometimes that's just the case. It doesn't always mean that you're going to abandon care if maybe there's some other metric that is helpful. Maybe some with their activities of daily living are improved, or there's just a modest but inconsistent improvement with their pain, or a reduction of medication, for example. Anything like this is going to demonstrate a positive. So you want to make sure that that's included in your reassessment if you're asking for additional care. Or we don't really do too much requests for additional services. In other words, because we're not referring to another specialty. We might just be asking for additional visits or additional treatments. Management and continuation of care is they're saying is, the VA, like everybody else, doesn't like to pay for managed care. They want a care plan that results in 100% or improvement, or a referral for surgery or more medication. It's similar, that's what we see from all insurance. They don't like the idea that you're going to see somebody once a week indefinitely, even if it demonstrates a benefit. It's just that that's not a treatment strategy. It's a bit of a zero-sum game. They want it to end at some point. Like I say, whether that's with a surgery or increasing medication, but they want it to end. And go ahead.
Question: if they increase the medication, that will be the same thing as acupuncture.
I would agree.
If I remember correctly, according to HIPAA, you cannot ever tell a patient how much pain they're in. You can't tell them that. A doctor can't go, if you're in pain, the doctor can't go in and go, oh, you're not in pain. You don't have the right kind of face. Therefore, you're not in pain. That's not, they can't.
I agree with you. And I think that the standard of care when it comes to pain management, especially in sort of I say we're not quite in a post-opioid space, but we're getting through that, is that there's been a reassessment of how to quantify and qualify painful conditions. So I think there's more movement in the minds of medical directors and policymakers to get into this management place where they're saying, look, if I continue with a protocol of, let's, in this instance, we're talking acupuncture, so we'll stay with it. If I have a protocol of acupuncture that includes 1 episode of care every 7 to 10 days, that I can reduce my butalbital for migraines, or I can reduce my OxyContin, or I can reduce my medication, or I can maintain without having to increase my medication, that there is a net win there. And that there is more of an appetite to approve extending care and extending episodes of care for interventions like acupuncture. It's just not universally adopted. It's going to be kind of on a case-by-case basis, and you can see this in the protocol that's described here, is that it's tied to that sort of older mentality. But I think that, the better job we do with our documentation, the better job we do with patient communication, it can be helpful for them to be able to communicate effectively with their provider and convey that this helps with my quality of life, my skills and activities of daily living. It reduces or maintains my medication so that I don't need more. And that ultimately all of those things turn out to be positives for continuing your care with acupuncture. It's just that based on the policy as we just saw it, they're only giving 28 visits that are front loaded on the first 6 months of care. And it's not the same as saying we're going to give you 28 visits, in which approximates to once every 2 weeks, which may even be more manageable for a chronic pain patient to see every 10 to 14 days rather than front loading and then not having care on the second half of the year. But again, it's a bit of Mount Everest. We're not going to be able to move that overnight. I just wanted you guys to see what the how these authorizations are being generated, what the expectation is for the providers when they're creating those authorizations, what they expect to see in terms of a plan of care, and also so you know where they're going to be flexible and where they're not. They're going to be flexible in the first 6 months to give you, 20 visits to demonstrate real improvement, and there's probably some room for, for the prescribing provider to authorize additional care. It's just not going to be done without probably bending the rules a little bit or them demonstrating some extenuating circumstances. And that's our job, to document it effectively so that we can give them the right ammunition to say, hey, this is the extenuating circumstance. We're going to go the extra mile and give this veteran more care because he's doing so well, and we don't want them to revert to losing ground on the benefits they've achieved. And it's in part a bit of a patient communication thing with our veterans to make sure that they understand how to advocate for themselves in terms of communicating effectively with their provider, so that they understand, what the other side of that equation looks like. And these are the things that they need to be able to articulate. Okay, guys. So we'll send this second page, the second document. I think it's just helpful as a resource for you guys to say, hey, this is what the VA's policy is moving forward.
Are you going to be sending that documentation guidance page? Or where is that? Where can I find that for my stuff?
I don't know. This came to me from a provider that got it from Bay Pines, and it may have been just sent to them as a regular email. But this is something that we can share. It's a community care. Basically, this is probably, if you think of the CCN, Community Care Network, documentation kind of through Optum, in the way that Optum is doing things. Okay.
I will post both of these on the announcement sections of the website and the veterans page.
Thanks, Ellen. It's good. And like I said, I'm sorry I sent you 2 letters as usual within 5 minutes of each other, but I'll send the one with the Arizona address on it for being posted. Okay.
Yeah, and I'll email them out to the participants as well. All
right, guys. We're at about 45 minutes in, and I'm open to any other questions that you guys have.
Ellen, was there something about a class for writing the reports their way?
Yeah, it's we're going to have Maury West as an insurance biller, and she's going to apply it to Florida when she teaches the class here. She has one online that's more general, Maury West seminars, but we're going to bring her here in July. Let me see if I can quickly get the date. It'll be a 2-day workshop. I think this is a Monday night. We'll have a brief introduction with her on a Better Business on June 22nd, and then June 17th or 18th and 19th will be a 2-day webinar. The first day is the basics of billing, and the second day is bulletproof your documentation.
Right.
exams and bulletproof your documentation.
I think that's key, guys. Going forward, you know, Optum and companies like Optum and Triwest that are third-party administrators, you know, they really probably you know, how they're reimbursed, I'm not entirely sure. They may have sort of a percentage of, you know, like a standard rate for managing a case for a veteran, and, you know, what they don't spend, they keep, like a lot of TPAs, how they work. So there's a lot of incentives in whether it's Medicare or and probably in the VA as well to reduce the cost of care overall. And part of that is incentive deals with how those third-party administrators allow care to be provided through their provider network contracts. So my expectation going forward is that we're going to have more and more scrutiny about documentation because, you know, in a tough economic climate, that's, you know, they keep what they don't spend. And if they can put us in a position as providers to provide care, get good results for providers, and then pull back 10 or 15 or 20 or more % of what they're paying us and create incentivizing a profit for them that way, they'll do it. And they're just going to continue to increase the burden on providers to make sure that the documentation is, as Ellen described, bulletproof, so that when they want to challenge, you know, did you really need to do 2 units of manual therapy, and you didn't provide a reason, you know, for why you did it, what the treatment objective was, how you measured an improvement on that, we're not going to pay you for it. And we're used to being able to say, hey, I did this, I did this, I did this, and now I want to get paid for it. But we're coming up against a new reality in that way as a profession. I think we're, you know, they're opening their arms to say we want to include more care that you provide. They're opening up, so they want us to provide more care, but they're gonna apply greater scrutiny to our documentation. Okay, guys, I'm sorry my audio is a little fuzzy tonight, so I'll leave it there. I think the only other thing we were going to cover was sort of just an introduction to the question of Medicare, and now that there is a Medicare fee schedule and CMS is going to cover acupuncture for low back pain, there's this discussion circulating in the country about how acupuncturists want to advance into a primary role in terms of being a provider for Medicare services and to be able to provide services that are unsupervised. It'd probably be healthy for our bottom line, as well as create more access and ease for us to deliver care directly. But it also opens opportunities for our colleagues to work in a variety of healthcare delivery settings, like hospitals and rehabilitation centers and other places where acupuncture services can be used. But because then typically or traditionally we've been outside of the Medicare reimbursement model, it's been hard for facilities to open those jobs to licensed acupuncturists. So we have a survey that was produced that only has a handful of questions that is designed to just get a first pass and generate some data and feedback in terms of where the membership stands on the question of pursuing this question of expanding the Social Security Act to include licensed acupuncturists as providers for Medicare services. And there's definitely pros and cons. You know, there's a fair amount of information for us to be well informed about. But first, before we get into all of the details about it, we just wanted to sort of get some feedback as to whether or not this is something that, as a provider, you're looking for. It's something as a provider you just detest the idea of it. But we want to act sort of in concert with what the membership thinks is best, and then see how that fits into a national agenda that includes a multi-state and national effort to raise money, to develop the right type of campaign and project that could actually result in effectively lobbying Congress to open the Social Security Act, enact a new law that effectively implants acupuncturists side by side with medical doctors, osteopaths, advanced nurse practitioners, chiropractors. And it's a limited group of physicians that are allowed to have that autonomy in terms of CMS provider services. So what I just wanted to mention it, and then ask that you keep your eyes open for an email that asks for you to complete a survey. The survey, I think, is going to have less than 7 questions. It's relatively straightforward, but it's just meant to be a first pass, and then we can take a closer, detailed look at things that are either questions that come up, concerns that come up, or how to move forward with some momentum on that question. Okay, is there any questions on that this evening? If not, you'll see a survey coming out, and there'll be lots of opportunity to discuss this question. Jennifer Broadwell and Joshua Jackson, another board member, are going to be leading the discussion with the national organizations on the insurance committee to continue to fact find and provide more surveys and more information so that we're all able to make a well-informed decision about whether or not that's the best choice for us as a profession, the best choice for us as individual providers, and move from there, okay? Thank you, Ellen. Thanks for everybody's attention. Again, we got about 10 minutes left in the hour. If there's any questions, I'll take it.
There is a long post in the chat from Laura that looks like some good information. If anybody, if you haven't looked at the chat button, take a look at that. And we're open for more questions on almost anything. All right. Well, thank you all on behalf of the FSOMA board. We appreciate you attending, and please let us know how you're doing.
Thanks, guys. I hope that's helpful. And if you have any questions, obviously Ellen's available to you, but you can always email me, david@fsoma.org, and I'll be happy to answer your questions, offline. Thanks, Ellen.
Thank you. And I will be posting the recording on the website too, probably tomorrow morning. All right. And sending out the other information tomorrow
Thanks,
morning.
Ellen. I'll send you that letter now.
All right. Thank you. All right. Bye-bye.
Thanks, Bob.